All right, so today we have the pleasure of speaking with Dr. Corey Babb, a board-certified gynecologist who has dedicated his life to bringing awareness and acceptance to female sexual health. He is a Menopause Society certified practitioner, fellow of the International Society for the Study of Women's Sexual Health, which is also known as ISHWISH, and a member of the International Society for the Study of Vulvovaginal Disorders. We also have Dr. Jaclyn Lanthier with us. Jackie holds a doctorate in philosophy neuroscience and is a very active patient advocate for lichen sclerosus. She sits on the board of the Lichen Sclerosus Support Network, the steering committee of CORALS, which is Core Outcomes for Research in Lichen Sclerosus, and is very active in the LS medical space and community at large. So thank you both for being here. This is so exciting. It's
Thank
going to be
you.
a great discussion discussing all things lichen sclerosus, which is an important but often overlooked pelvic health condition. So if you've never heard of it or suspect you may have it, tune in. So let's get started. And let's start off maybe by just defining lichen sclerosus, explaining what it's all about and what symptoms people should be looking out for.
Well, I guess I can start with that. That's fine. So, lichen sclerosus is an autoimmune disease, so meaning that the body's immune system kind of attacks, in this case, the skin, a specific layer of the skin. And we often see it on the vulva, although it can also appear outside of that. Personally, I had patients who've had it behind their ear, on their breast, on their arm, and it can also affect people with penises as well. So you can see it on the penis, on the scrotum, things along those lines. Typically, it's going to have a kind of an itch or an irritation as its initial symptom, and that can then progress to the point where that itching is almost unbearable, can cause pain, scarring, infection, just kind of going down the path of what can happen with skin disruption. And then it does carry with it a very small chance for developing into a specific type of skin cancer if it's not treated.
Okay. Jaclyn, did you want to add anything to that?
Well, I think that's a great, in a nutshell, kind of what's going on with our skin. And yeah, I mean, I know a lot of folks that have vulvar and perianal involvement. Perianal involvement is something that's a bit trickier to catch in that it's kind of challenging to find the right provider who feels comfortable looking at that skin. I've had many gynecologists just flat out say we don't look there. So typically either a vulvar specialist or dermatologist may have to get involved if you're having symptoms in that area because there can be perianal involvement as well.
Mhm. So, what kind of specialists do diagnose lichen sclerosus?
I mean, it can be from a gynecology standpoint, a dermatologist. I mean, really anyone who is looking at that skin could potentially diagnose it. But typically most patients are going to see either a GYN or a dermatologist or maybe a urologist, obviously, if they have penises.
Okay.
Yeah, sometimes in Canada and Europe as well, often our first point of contact is going to be a primary care physician or a GP. And some of them who kind of take a special interest in these conditions may make a clinical diagnosis to start. They'll often give the clinical diagnosis and then refer out to a gynecologist or a dermatologist to get that confirmation. But sometimes those types of doctors can make a clinical diagnosis. They're typically not going to make a biopsy diagnosis because most GPs, PCPs don't have that type of equipment in the office to do, so they would refer out in that instance. But some folks get their kind of first diagnosis there.
And how is it? So, how are you completely diagnosed with LS?
So there's two main ways that you can be diagnosed. There's clinical and biopsy. So clinical would be where you're looking at the clinical picture, i.e., what are you seeing on the vulva? Are there any texture changes? Are there any color changes that are indicative of lichen sclerosus? So that hypopigmentation, loss of pigment, is there a thickening or a kind of crinkling of the skin? Looking at those types of things, and then also taking the patient's history. So what are the symptoms that they're coming in with? And in instances where the symptoms and the clinical signs are kind of paint a picture of this is without a doubt lichen sclerosus, a clinical diagnosis could be made. That's typically going to be with a provider who is very, very, very knowledgeable in lichen sclerosus, that they can have that level of confidence to diagnose without a biopsy. Otherwise, you are going to look at a vulvar biopsy to make that diagnosis. And some, some specialists will just do the biopsy initially anyways, just to get that confirmation, because as Dr. Babb can probably speak a little bit more to, it's not always easy to see that clinical picture. And there's a lot of other conditions that have hypopigmentation. So it could be vulvar vitiligo or something. There's other conditions that can cause thickening. We can have lichen simplex chronicus can present as thickened skin. So it's not always that simple. I make it seem simple sometimes when I discuss the clinical diagnosis, but it's actually kind of complicated because there's so much overlap both in symptoms and in signs of these vulvar skin conditions and other genital pelvic conditions that sometimes, a lot of specialists are going to say, let's just do a biopsy so we know exactly what we're working with.
Mhm. And I hear it's often difficult to get a diagnosis and it can often take years. So are you seeing, Dr. Babb, are you seeing a lot of this?
So, I mean, our clinic is very specialized in what we do. So we often will have those patients that have been to, 5, 6, 7 other providers. They've been told, oh, this is a yeast infection. That's probably the most common thing. I just thought I had a yeast infection that kept occurring, month after month after month, and they were treated with yeast medications, or, maybe it's a vaginitis as well. And so they kind of get this mix of incorrect diagnoses just based off of symptoms alone. And this can come from even other, gynecologists or dermatologists too. But yeah, it is unfortunately something that it's rare, at least in my patient population, for someone to have gone to one provider, they say, oh, this is this, and then they get treated properly with that.
And I also hear a lot of perimenopausal women, menopausal women are being misdiagnosed. And why is that happening? Is that due to atrophy or?
Yeah, so you think about as kind of hormone levels change, especially estrogen levels and estradiol specifically in the genital tissue, you're going to see, especially if that patient is not on any type of hormone, supplementation, some thinning of the skin, some change in architecture naturally, just as that kind of aging process occurs. Now, that also means the skin is less resilient. And so for patients who have LS that may not have ever had a flare of it, going through the menopausal transition may result in an exacerbation or a worsening of their symptoms.
Hmm. So let's talk vulva checks, because I know that it's very important to check your vulva and extremely important for those who struggle with LS because they're more susceptible to vulvar cancer. So can you discuss that a little bit?
Yeah, I don't know about Corey, but we at Lichen Sclerosus Support Network, we pretty much recommend doing a vulva check once a month.
Agree.
Because we don't want to do it too often because that can kind of exacerbate anxiety. And, at least it did in my case. And I see that a lot in the LS community. But once a month, really setting out, 5-10 minutes where you're going to slowly look at all the parts of the vulva. So we'll typically tell people, the position that you get into depends on your body type, accessibility, a bunch of different things. And we have videos on how to do vulva checks. For me and my body, that looks like kind of reclining. I put a bunch of pillows behind me, recline, and then kind of, legs up as if I'm in like the stirrups. And then I have a mirror that has a little stand, and I can kind of stand that back. And then I don't have it with me, but I have this like headlight. It kind of makes me look like I'm going on like I'm Dora the Explorer going like cave adventuring. I bought it so that I could like read at night without putting the big light on. And it has this like, so it's a head strap, right? It looks funny. And then it has this light or this mini flashlight on, and then you can like angle it and you can change, like you can dim it and stuff like that. So I basically put that on my head and then angle it down so that I can see the vulva. And then it's really just going through all of the parts. Okay, looking at the mons pubis. Does everything look good? Am I noticing any skin changes, like a new mole or something that I didn't notice before that I may want to bring up to a dermatologist? Work my way down, looking at the clitoris. How's the hood? How's the gland? Is it moving? Have I noticed, are there maybe some new adhesions, which is just, a word for fusing where skin kind of sticks together. So sometimes that clitoral hood can kind of stick to that glans. So am I noticing any change there? Okay, outer labia, again, looking there, inner labia, kind of just working my way down perineum, just looking for any changes in color, in texture. anything that I may think I'm going to bring this up with a healthcare provider. If I notice any changes, I'll typically just write them down and, make an appointment to discuss with my healthcare provider. Oftentimes the changes that we do notice can be benign. But, better safe than sorry. Just check with your healthcare provider if you notice any changes. This is my kind of philosophy with that.
Is there a tool out there where people can, because I think you're probably more educated and know what to look for, but for people who are a little bit less, aware of what's going on down there, is there something out there where they can sort of have a walkthrough for their
So we do
vulva?
kind of, yeah, we do kind of have a video where we walk through it now for a bunch of reasons. We can't have real images of vulvas in our videos because they just get flagged and taken down. But there are websites where you can look at images of lichen sclerosus and also of vulvar cancer to get a better idea. Because it's one thing when I describe, an asymmetric, purple-y, change on the vulva or something like that. It's another thing to see it. So there are ways that you could see, what vulvar cancer looks like, what lichen sclerosus looks like, some of the changes you want to, if you want to get that visual reference, I talk you through it. But yeah, if you're visual, there are ways to access that. I would just caution too that that can be incredibly triggering to see some of those images, and it can be really hard. So, maybe do a mental check with yourself first. If you're going to take that extra step and look, do I feel prepared to see this? And otherwise, I say that's what the healthcare provider is there for. If you're seeing anything that's changed on the vulva, document it, take a picture, bring it to your doctor and check. For instance, one time I noticed like a purplish, it looked like a bruise or something around my clitoris, and it just appeared overnight. Now, in the early stages of my journey, I really struggled with health anxiety, and I immediately went to, oh my gosh, this is cancer, and kind of was freaking out. So I made an appointment with my healthcare provider. But one thing I did do was I took a picture, and I'm very, very glad that I did because it took me 2 weeks to get into my provider. And by the time I did, it was completely gone.
Hmm.
So had I just shown up there, she probably would have said, well, I don't know, not sure what that could have been. I can't really say because I'm not seeing anything on your vulva. Whereas I was able to show her the picture and be like, this just kind of popped up overnight. What is this? Should I be concerned? And should I make any changes to how I treat moving forward if this happens again? And she was able to just kind of reassure me that that was just bruising that can sometimes happen with lichen sclerosus. And in the case of a bruise, it's just kind of going to fade on its own. And there's nothing I needed to change with respect to how I was applying my clobetasol. I also got that peace of mind of, okay, we're not talking about vulvar cancer or even an Ellis flare per se. I know what to do if this happens again. But that's why those pictures can sometimes be helpful because seldom can we have something occur and then get into a provider like same day. Even if you're private, like that's very unlikely. And some of these things may resolve by the time. If you're getting a rash from something that you used, the rash may resolve by the time you get into the office. And the clinical picture with vulvar skin is really important. It really is. We really do want to see that skin to see what's going on because I could call up Corey and be like, yeah, my vulva's all red and irritated. And that could be a trillion things from that very vague description. Without seeing that in person, it's kind of a challenge. And so that's why I also recommend, there's a change, something you're concerned about, something you want to ask about, take a picture. There are ways to encrypt your photos so that they're kind of private off your camera. So if you've got like a little kid or someone running around that sometimes plays on your phone, you don't have to worry about them kind of stumbling on. It's kind of hidden behind these like security vaults and then encrypted. So,
Mhm. So what about treatment options? Let's talk about treatment options because I think a lot of people out there aren't aware of what there is. And if maybe we can also talk if there's any new um, advancements in treatment for management.
Sure. So the mainstay and kind of the gold standard is going to be an ultra potent steroid, and typically that's going to be clobetasol, halobetazol, betamethasone, or mometasone. Those are kind of the big four. And some people tolerate one more than the others, but those steroids have been shown to reduce that chance of the squamous cell carcinoma, the type of cancer. So that is why they are the main treatment option. Now, some patients may get improvement with less potent steroids, so like something like a triamcinolone or even like a cortisone, but it doesn't have that same reduction in the cancer risk. So that's kind of the mainstay of treatment. Now, for patients who are perimenopausal, menopausal, or even sometimes, who are just having a lot of irritation, we will also add a topical estrogen. And that can be either just a regular vaginal estrogen that you're putting on the vulva. You can have it compounded. So that's kind of another type of adjunct therapy. Then you start getting into some of the other secondary therapies. So a calcineurin inhibitor like tacrolimus or pacrolimus. Those can work. I think I have a handful of patients that they didn't respond well to corticosteroids, so we have them on that. Once again, though, you don't have the cancer reduction risk. That's kind of the big thing there. And then you kind of get up into more of the kind of experimental things or things that are treating specifically symptoms of the LS, like burning or itching or things, but aren't really changing the actual kind of skin issue that goes along with the condition.
And can these be used long term? Or
Yes, actually. So, and that's one thing we'll see a lot of times for patients. They may come from a provider who's not as knowledgeable, and they said, "Oh, they told me only to use my steroid for 2 weeks, or
Mhm.
use it for a month, and then don't use it again unless have an issue." And really, the amount of steroid you're putting onto the vulva is small, for one thing. The second thing is that tissue, even in severe LS cases, is still fairly thickened. And so the main issue that you worry with it, which would be skin thinning from chronic steroid use, we don't really see in patients who are appropriately using their therapy. And so even for someone who is symptom-free, has no clinical signs of disease state, they still want to be on a maintenance dose of their ultra-potent steroid, either once or twice a week, kind of depending on who you talk to. And that's going to be indefinitely.
And is there any type of laser treatment or anything new on the horizon?
So the laser therapies, platelet-rich plasma injections, exosome therapy, those kind of exist in a kind of almost like a realm of let's try and treat symptoms. It's not treating the disease. So
Right.
for instance, we will have patients in our office that have severe LS that are still bothered by irritation or pain in that area that we can do like platelet-rich plasma or PRP to the lesion for that. But
Mhm.
it is not, and that's kind of my like, very burr, burr, burr type thing. You're not reducing that skin cancer risk by doing those therapies. But some people do find a benefit in the symptom of the condition, a reduction in symptoms using lasers or PRP or things along those lines.
Okay. What about emollients?
Yeah, I love emollients. I tell everyone with vulvar lichen sclerosus, use an emollient. Steroids can have a slight drying effect. So for that reason alone, it can be nice to kind of put moisture back in the skin. And if we think about it, dry skin is itchy skin, it's irritated skin, regardless of its location on the body. Even like, Canada, as you know, Marnie, like our harsh winters up here, my face will be incredibly dry and it's like irritating. Even when I talk, I'm like, ugh, I hate it. It's like pulling and it's tight and it's itchy and it's just not fun. And so if we've got that feeling, on our vulva and we have lichen sclerosus, it kind of can even like exacerbate the itch that you already have. So we want to kind of alleviate that. It can be very soothing. Many people say, oh, once I added the emollient in addition to my treatment plan, I really started to feel better. And emollients, they can be as simple as a one ingredient plant-based oil, such as coconut oil. And then there's also different brands on the market where you can look specifically for a vulvar emollient. And an emollient is basically just a fancy word for a moisturizer. So there's different moisturizers, balms, and then there's barrier creams as well. Barrier creams tend to be a bit thicker in consistency. I recommend a barrier cream more so if you have active cuts or fissures on the vulva. Can be really helpful because if you have an active cut or fissure on the vulva and you're urinating, for instance, when urine gets into that open skin, it can kind of sting, burn, irritate. So if we can create this kind of protective barrier, that can be helpful. I also will sometimes use it if I'm going swimming in a pool that I know is heavily treated with chlorine, just to kind of create a little bit of a barrier between the chlorine and the vulvar skin, as chlorine can kind of dry me out a little bit too. So instances like that is more of a barrier cream. But for day to day, a basic emollient or a balm is really nice. I've been trying recently the Enchanted Rose Balm by Intimate Rose. And I will say I was a little bit nervous in the beginning because I heard the name Enchanted Rose, and I thought it was going to smell like a bouquet of roses, which I wasn't sure I wanted to be smelling all day. But it actually has a really, really neutral smell, which I like. When it comes to putting things on the vulva, I like it to be pretty basic, nice ingredients. And the texture, the consistency is incredibly nice, stays on well. And yeah, I've really been enjoying that one.
That's great. Corey, did you want to add anything?
Oh no, I agree. We tell patients if you're, let's say you're doing daily steroid therapy and you're putting that on at night, in the morning, you're going to want to put on some sort of emollient. So you always kind of have something on the vulva that is maintaining the moisture level there. So
yeah, because your steroid basically comes in a sense with a built-in moisturizer, right? Because it's never just the medication, it's the medication in a base. And at least my base for clobetasol is petroleum jelly.
Well, I think that's a really important thing too. When you're sometimes we'll see providers who will send a steroid cream versus steroid ointment, and creams by definition have around a 50% alcohol concentration. And that helps them absorb into the skin quickly, definitely. But if you've had a paper cut and you put like hand sanitizer on your hand, you know how much that burns. And so imagine that kind of amplified if you have a lot of fissures or cracks in the skin. Now you're putting this cream on, it's going to kind of light things up. So the ointment form of the steroid is really what you want, because it's going to provide that barrier as well, and it allows it to soak into the tissue more and then deliver that medication kind of at a more gradual rate.
It's so great that these moisturizers are coming out on the market because, just like you were saying, you get dry lips, you put chapstick on. It's the same thing. You get dry lips, you put moisturizer on, so it's great that there's a multitude of products coming out now and people are starting to really become comfortable with using them. What about pelvic floor muscles? How do they get affected by lichen?
Yeah.
They can definitely be affected, that's for sure.
Yeah.
I'll let Corey go and then I'll tell my personal story.
Well, so one thing you think about, the body's natural tendency when we have an area that hurts is to try and wrap around that. You think about if you've got a wound, the skin kind of tries to go around it, it forms kind of scar tissue over that. Well, so now you've got an area on your body that really you can't help but use. You are, whether you're walking, you're sitting, you're going to the bathroom, your pelvis is always being activated. And for someone who has pain, irritation, itching in that area, it sometimes can become a focus of their concentration. And when that goes on, we start to see those pelvic floor muscles get involved too. And so you've got this combination of pain causing pelvic floor triggering to almost like a hyper awareness. They're like trying to, is this affecting my vulva? What am I feeling all the time? And it causes everything to clamp down. So you see a lot of patients with vulvar LS will also have pelvic floor dysfunction as part of their condition, not because the LS is getting and infecting the muscles, but because of the response that the patient is making to the condition itself.
100%. I definitely had an incredibly tense pelvic floor by the time I got my diagnosis. And it makes sense to Corey's point. It's a reactionary thing. So, we're talking about misdiagnoses in the beginning. Well, it took me 10 years to get my diagnosis. That was 10 years of pain with sex and very intense pain with sex. So my body unconsciously was always tensing up against that pain. So if you think for 10 years, my muscles were just locked like this, trying to, in essence, protect me from the pain. But in doing so, it's actually amplifying the pain, because now we've got the pain from LS and now we've got pain coming from the tight pelvic floor muscles. And I remember shortly after my LS diagnosis, my provider didn't tell me this, but I just walked myself into a pelvic floor PT clinic because I have degenerate disc disease, and I've spent a lot of time in those types of clinics. And when you're in the waiting room, you see all the bios of all the providers up there. And I remember seeing pelvic floor PT, and I was like, how strange that there's a PT just for the pelvic floor and everyone else does like full body. And, because you're bored, you're just reading. And I remember reading, okay, what do they do? Pregnancy related things, constipation, urinary issues, pain with sex. And so after I got my diagnosis, I thought, well, if they work with pain with sex and I have pain with sex from LS, maybe they can help me. So I walked into the PT's office and we did an assessment. And it's quite comprehensive. But when we were doing the internal assessment, she inserted one finger into the vagina and first asked me, tighten your muscles. So essentially do a Kegel, no problem, death grip. Then she goes, great, release. And I'm sitting there all proud, like, yeah, gotcha. And she's like, no, I need you to release. And I'm like, I did. She's like, no. And it took me 5 minutes and it was gradual. It was like, and it took all my concentration. And in that moment, I realized, oh my gosh, it's like my muscles do not know how to relax anymore. They are so used to being in this chronically tense position that my body doesn't even know how to relax. So we had to, I worked with my PT there for quite some bit using a combination of, dilators, different breathing techniques, trigger point release, all of that to kind of work through that. And I definitely think that was incredibly beneficial overall.
Pelvic PT can be so beneficial for so many conditions.
Yeah.
Because remember, tightness does not equal strength. And that's the other thing. Those muscles are so spasmed. Doesn't mean they're super strong. They're just contracting like crazy. So a lot of these patients will actually have weak pelvic floors. But, it's a whole, it really requires a very, good pelvic floor physical therapist and to really help get things to get to where you want them to be.
And it takes sometimes quite a bit of time to get to where you want to be. So people have to learn to be patient when it comes to, getting back to that place. What about mental health? Let's talk about the mental health piece. I think, Jaclyn, you can probably speak to that quite a bit. So how can it impact mental health? And what advice do you have for managing the emotional side of the condition?
Yeah, I think, the mental health side is such a huge piece of lichen sclerosus. And you can see that even in the literature when you look at quality of life and anxiety, depression. This is highly reported in this community. I think it has to do with a multitude of reasons. One, it's a condition that affects a part of the body that is often stigmatized. There's a lot of shame around it, depending on religious background, that can also kind of intersect. And so it's something that, when my back hurts, I can just tell everybody at the party, my back hurts. And all of a sudden people are rushing to me with, heat pads and Tylenol and stuff like that. But if I say, oh, my vulva hurts at a party, people are going to look at me like I'm either gross, wrong, offensive, or just flat out weird. So there's a lot of isolation that can come from that because we can't talk so openly with our colleagues and our friends and the people that are kind of in our support system already. We feel kind of isolated and disconnected from them. Also, a lot of patients when they're first diagnosed are told by their providers, oh my God, this is so rare. I can't believe you have this. And not only is that a myth, it's not true, but that further adds to that sense of alienation because then I feel like, wow, I have this super rare condition. Like almost nobody else has this. It's just me, furthering that isolation kind of piece. So you can feel really isolated and alone. There's a lot of shame. There's also a lot of grief. Grief is something that comes up a lot. And the grief piece is often around grief of sexual identity if your sexual health is impacted by lichen sclerosus. Some folks are so impacted by pain with sex, for instance, that they can no longer have sex. not indefinitely, but at least for a period of time until they kind of heal that skin and work on the pelvic floor. But how that intersects with relationships, dating, our partners, our sex life, there can be a lot of grief there. The person, you know, who I thought I would be in my relationship is not the person I can be. That can be hard. Also, you know, one of the signs of lichen sclerosus can kind of be changes or loss to the vulvar architecture. So, you know, for instance, by the time I was diagnosed, my inner labia, the labia minora, were completely resorbed into the labia majora. So I kind of lost those at that point. So losing structures in that sense can be very hard. And I will say, as a patient advocate in the community, that's probably one of the pieces that people struggle with the most, is the changes to their architecture and that loss. And so there's a lot of grief around that, grieving that lost architecture. And I always say, you know, when we're little, we see our grandparents aging. We know that gray hairs start to come in. We know that wrinkles occur, but no one talks to us about the changes that occur to our vulvas. So it's incredibly, like, I didn't know parts could just fuse together or resorb into each other. So it's quite shocking to hear that that's a thing, and then to see that happening on your body. So there's grief. Anxiety and fear is also really common. A lot of this can be alleviated or helped by proper education, but we live in a space where, you know, all countries' medical systems are, you know, imperfect. And if you have 10 minutes with a patient or 5 minutes with a patient, you barely have time to do the assessment. You give the diagnosis, the treatment, and they're out the door. And the problem with that is that there's no education on what is happening to their body, what this means for their future, and how they can kind of work towards symptom management and quality of life. Now, with a vulvar specialist, you have way more time, so they can really take the time to explain what's going on, explain the treatment plan. Here's where we're going to get you, you know, all of these things. But when we don't get that education up front, there's so much uncertainty. There's so much question marks. And what happens when we don't get that information? Naturally, we're going to go to Google. And unfortunately, Google, for all its greatness, there's also some not so great stuff out there. There's a lot of misinformation, and there's a lot of stories that you will encounter that lack context. And there's a lot of, you know, bias and things that we have to watch for when we're taking in this information. So if we go in a support group, we're reading all of these horror stories, you know, people that are just in so much pain or whose relationships have dissolved. And I remember going into these spaces and just reading bad story after bad story after bad story and thinking, this is my future. This is now my life. Because I didn't know there were any good stories out there. So my impression was there's no hope. So of course I'm going to feel anxious. I'm going to feel depressed. I'm going to, you know, really be going through it. And that was one of the reasons that I started the Lost Labia Chronicles. Once I did kind of get into remission and kind of reclaim my life, was I wanted to highlight that there are many positive stories. Many folks get into remission, have great quality of life. But again, there's a bias at play when we go into these spaces, because the people who are thriving, who are doing well, who are well managed, they're not posting their stories in these support spaces. They're out with their families hiking. They're doing a conference. They're traveling. They're swimming in a pool. They're doing a triathlon. They're not there. So that's that bias when we go into these support spaces, is it's going to be the people that are struggling who are sharing their stories. So that gives a perception to someone looking in of there's no hope, which again is just going to make that anxiety, that fear, that depression worse. Also, you know, sometimes providers will give a really Coles Notes version of what's going on. So mine was like, it's autoimmune. We think there's a genetic component, causes sexual dysfunction, can lead to cancer. Here's some clobetasol, out the door. Can lead to cancer. And I went into health anxiety mode and was convinced I had vulvar cancer, but that wasn't presented with any context. So if we put that into proper context, we know that there's a 2 to 6% risk, so slightly above baseline population risk. So it's a small risk of developing. But then we also know from our research, as Dr. Babb was alluding to earlier, is that we can kind of bring that percentage down when we treat with high potency topical corticosteroids. And so if we just educate, a lot of that fear, a lot of that anxiety can kind of settle a bit. But when we're left with big question marks and only Google at our fingertips, it is incredibly scary. And it's also hard when, your healthcare provider may not be the greatest. They either don't know a lot about lichen sclerosus, or they dismiss you and gaslight you. So there's just so much complexity when it comes to how mental health is affected. And I also want to say that not everybody's mental health is affected. There are some folks who get their diagnosis and they just use their medication and they don't really find that they're too affected by mental health. Everybody's different, but it definitely is a big piece. And I think, when it comes to alleviating some of that, mental health strain, education, right? Good evidence-based education, understanding what's going on in our bodies and how we can kind of treat, get symptoms down, get things settled, improve quality of life. That can really be helpful. Peer support can really be helpful. So spaces like Lichen Sclerosus Support Network, they do virtual meetings, they have memberships where you can talk to, other peers with lichen sclerosus. And that can really be helpful in creating a sense of community, and community can kind of offset those feelings of isolation, where it's just me, it's only me, I can't talk to anybody else. Now we can talk to a network of peers who have this. And I mean, there are groups out there with like 20,000 members in them. So like there's tons of people around the globe. So some kind of peer support. If you're really struggling with your mental health, bringing in some kind of professional. So for me in the beginning, my health anxiety was way too high. And I knew that. I was like, my depression, my anxiety, my health anxiety, this is not something that peer support alone is going to help with. So I found myself a sex therapist. I went the sex therapy route because a lot of my fears and anxiety had to do with the sexual health piece of lichen sclerosus. So I sought help with her. We talked about, all the sexual health implications. We worked through a lot of my health anxieties. So some kind of therapist, counselor, sometimes they can be brought on. If there's a chronic pain component, pain counselors can sometimes be really good with that. That's something we don't talk about a lot. There are pain clinics where you can get pain counselors and different types of therapies there for chronic pain issues like DBT, CBT, all of these types of things. So really, paying attention to all of that, but good support, good education, and reaching out to professionals, I think are going to be the big ones.
Mhm. Corey, did you want to add anything?
No, I mean, yes, concur.
Yes.
Yeah. It's
No,
always
I mean,
great.
I think, Jaclyn kind of hit it on the nail on the head there with it. Like, I mean, this is a condition that is very multifactorial. It's going to affect, people's sexual health, their mental health, their, physical health, to varying degrees depending who you are and kind of how value those things in your kind of day by day. But I think that the take home message is that this is not a super duper rare disease as a lot of people kind of think about. I mean, we see it all the time. And there are lots of resources out there for patients who have this, no matter where they are in their LS kind of journey.
Mhm. Amazing. Well, thank you both. This has been extremely enlightening, and it's going to be great information to get out there. I think very much needed. And again, I will post your support system and networks up so that people can contact you if they have further questions or if they want to join your network. Um, all right. Well, thank you again. And this has been a real pleasure, a real treat, and hopefully we will speak again very soon.
Yeah, thank you.
Thank you.